Good afternoon, everyone, and welcome. Thank you so much for joining us today, May 21st, to hear more about the work done around opioid stewardship. A few housekeeping announcements before we get started with the presentation. All lines are muted. For those of you using your PC audio, we ask that you please mute your lines throughout the presentation due to additional noise and feedback that may occur. Throughout the discussion and during the Q&A portion, please feel free to use the questions panel on the right side of your screen. This session is being recorded, and the recording and the slides will be available on the community site. There is a link already posted with the slides that are available. If you have any additional questions outside of the webinar, please email keystone@mha.org. My name is Christy Schaefer-Swadley, Manager of Safety and Quality at the Michigan Health and Hospital Association Keystone Center. During today's webinar, you're going to hear from 4 state hospital associations who led efforts around opioid stewardship, as well as the results achieved through those efforts. As a reminder, these are 4 of the associations working together through the Superior Health Quality Alliance, SHQA. We're glad to share this information and grateful you've joined us. So first off, you will hear from Tracy Radke. Tracy is a quality and process improvement specialist with the Minnesota Hospital Association, who works with members and committees in sepsis, coordination of care, readmissions, opioids, and mental behavioral health topics. She obtained her master's degree in healthcare administration through the University of Minnesota, Twin Cities, and is a certified Lean Six Sigma Green Belt with over 20 years quality improvement experience. Go ahead, Tracy.
All right, thank you. So today I will be presenting some information, resources, roadmaps, and toolkits that I hope you find useful in your efforts to reduce harm related to opioids. Next slide. Next slide. So MHA has created best practice opioid-related roadmaps, convened MAT boot camps, and participated in several opioid grants, such as the Minnesota Drug Overdose Substance Abuse Pilot, or Mendoza, North Star Opioid Consortium, and other state targeted response grants. Next slide. In addition to the opioid prescribing roadmaps, the neonatal abstinence syndrome roadmap was created through MHA's Perinatologist Committee, and MHA is currently creating an opioid stewardship roadmap. Most roadmaps include a toolkit and resources, all of which can be found on MHA's website under the Quality and Patient Safety section, and I will give you those links at the end. Next slide. So we have several roadmaps. We have the neonatal abstinence syndrome, which I mentioned. We have 87, which is all of our birthing hospitals in Minnesota that are using that roadmap. We created 3 opioid prescribing roadmaps that are based on the Minnesota Opioid Prescribing Guidelines that were issued back in 2018. And these guidelines were split out into different pain stages, which is why we created 3 separate: acute pain, post-acute pain, and chronic pain, and currently have 85 hospitals that are participating. As I mentioned, we are also working on an opioid stewardship grant, and then other roadmaps are the opioid adverse drug event prevention and the controlled substance diversion prevention roadmaps. Next slide. MHA's roadmaps provide hospitals and health systems with evidence-based recommendations and standards for the development of topic-specific prevention and quality improvement programs. They are intended to align process improvement with outcome data. Roadmaps reflect published literature and guidance from relevant professional organizations and regulatory agencies, as well as including identified proven best practices. MHA's quality and patient safety committees provide this expert guidance and oversight to the various roadmaps. Next slide. I'm not seeing the next slide.
Hey, Tracy, this is Melanie. I did advance the slide. I apologize if there's a delay in the connection.
Okay. So let's go ahead and move it again. There we go. Maybe I wasn't paying attention to where we were. Yep, this is perfect. Thank you. So the roadmap document is designed for use as an auditing tool, which then can also be a working document for quality improvement. Each roadmap is tiered into fundamental, there you go, stay there, fundamental and advanced strategies. The fundamental strategies should be prioritized first for implementation. And generally they have a strong evidence-based and published literature, in addition to being supported by multiple professional bodies and regulatory agencies. The advanced strategies should be considered in addition to fundamental strategies when there's evidence that the fundamental recommendations are not being adhered to consistently. They are organized by section, and you can see this brown column on the far left. That is what's considered a section. These typically are in different colors to help orientate people to which section they are in. And they address specific aspects of care. We also have operational definitions, which are shown in the red square. Operational definitions are meant to give additional information to ensure that hospitals are all interpreting them the same way. They also assist facility teams with roadmap auditing and identifying whether current work meets the intention behind the roadmap element. Then in the next column, we have line-by-line references and resources with live links specific to roadmap elements. The resources are linked within the roadmap and include journal articles, expert recommendations, electronic order sets, and other pertinent tools which organizations may use to assist in implementation of these recommendations. Next slide. I will keep going. It should be the Minnesota Hospital Association's neonatal abstinence syndrome subgroup was charged with creating a NAS roadmap and toolkit to better identify, screen, and treat NAS. The roadmap was developed based on published literature and other evidence-based practices that incorporate expert feedback from obstetricians, perinatologists, and neonatologists in close partnership with patient partners and multidisciplinary leaders. Can we see if the screen will advance? I will keep going, but it should be showing the neonatal abstinence syndrome roadmap. A subgroup was formed from the MHA Perinatal Committee to create a roadmap focused on NAS, and members included family practice, maternal fetal medicine physicians, nurse midwives, pediatricians, nurses, laboratory, pharmacy, and quality leaders. The roadmap was created over the span of a year and then was piloted by 4 hospitals before being rolled out throughout the state. And again, I mentioned earlier that 100% of our 87 birthing hospitals have completed the NAS roadmap. Next slide. The next slide should show you that there are 7 the different sections within the NAS roadmap, and each section represents a pillar of recommendations. So the NAS section currently with the highest adherence percentage is the neonatal care and NAS treatment. Next slide. MHA is currently working with the Department of Human Services to advance the creation and development of safe plans of care, as well as supporting the increased adherence to the NAS roadmap elements. And we are collaborating with appropriate stakeholders within the state and within hospitals to advance this work. In 2017, the Minnesota Department of Health convened an opioid prescribing work group of multidisciplinary clinicians and experts from across the state to create the Minnesota Opioid Prescribing Guidelines in response to a trend in opioid overdose deaths. And then based on these guidelines, we created 3 roadmaps based on stage of pain. Next slide. So this slide shows you that there were the three pain stages. So acute pain is 0 to 4 days following an acute event. Post-acute is 5 to 45 days, and then chronic pain anytime after that. The 5 sections within each of the roadmaps are patient safety, biopsychosocial and risk assessment, opioid prescribing, women of childbearing age, and then non-opioid and non-pharmacological pain management. Next slide. This is an example of the opioid prescribing roadmap for acute pain, and the recommendations include using, now this is, you can see is the patient safety section. And so recommendations within this section include checking the prescription monitoring program if you have one in your state, prior to prescribing opioids for pain. Another recommendation is that they should not be prescribed concurrently with benzodiazepam. And another recommendation is just considering co-prescribing naloxone to patients that are at elevated risk for overdose who are receiving these opioids for pain management. Next slide. Responses are entered into our data portal are, let me see, this is an example. I showed you this. MHA has an interactive portal for members to enter their adherence to each of these recommendations. And you can see there's kind of a checkbox under fundamental. And then within our portal, they answer their responses to those, and then they can analyze it within our portal. Next slide. So based on their entering every month, we pull data from adherence to our roadmaps, and the responses are then pulled aggregately to give us a view of the statewide adherence to the elements within the roadmap. So this practice allows us to determine where additional support is needed in an effort to increase adherence to best practices and standards. And here's the data from the opioid prescribing acute pain guidelines. So the graph shows that ending 85 is the number of hospitals that are participating and have completed the acute roadmap. The blue bars represent the adherence for each section. So such as patient safety, each of them represents the recommendations within that category. And then the green bar is showing the overall adherence to all elements or recommendations within the roadmap. And MHA runs these data reports monthly to determine process improvement efforts, strategies, and to track progress. Next screen. MHA is currently working with the Minnesota Department of Human Services in phase 2 of an opioid prescribing best practices and quality improvement for prescribers. And this work has resulted in creating an opioid stewardship roadmap. An opioid stewardship program provides pain management consultative services and works to identify patients at risk for adverse events, as well as potentially risky opioid ordering practices. And many leaders in healthcare quality and safety, like the CDC, Indian Health Services, and the Institute for Healthcare Improvement, support and promote an opioid stewardship program. So our comprehensive opioid stewardship roadmap includes key pillars for a sustainable program, such as leadership and culture, policies and procedures, prescriber and staff education, patient, family, and caregiver education, tracking, monitoring, establishing accountability, EHR support, and community engagement. Next slide. We have partnered with two Minnesota ECHO teams and hosted two MAT boot camps with close to 300 participants, but now we are again partnering this time with the Minnesota Department of Human Services to host 3 more boot camps over the next 3 years. And we hope to involve even more participants than we have in the past year or so. Next slide. And then we are also partnering with certified community behavioral health clinics in the state as a part of the North Star Opioid Consortium. And our purpose here is to build specific opioid and addiction care pathways, increase recovery and peer support programming, expand and build care coordination pathways, expand telemedicine, and engage community stakeholders in public education and awareness in rural communities. Next slide. And then we are also working with hospitals to encourage and support participation in the Mendoza pilot to determine the negative effects of overdose and inappropriate substance use on Minnesota hospitals. We want to raise awareness, which will help raise awareness of new clusters of drug overdoses in real time, so public health stakeholders can swiftly respond. We also want to identify new substances being used and substances that may not cause the typical signs and symptoms of drug use, along with clusters of use, severe illness, and or death, and identify who is most at risk in order to focus and guide prevention efforts. Next slide. So in conclusion, this is a picture of our website along with 3 links. The first one will take you to the Quality and Patient Safety webpage, where you can find many roadmaps, toolkits, literature, and other resources that you may find helpful in your opioid related efforts in your state. And then if you're interested in learning more about the Minnesota Opioid Prescribing Guidelines, there is a link there that will take you to the DHS website where you can learn all you want to know about those. And then another link will take you to the opioid prescribing roadmaps that we created, which haven't been published on our website yet. So with that, I will close and answer any questions.
Hey, Tracy, there are no questions in the chat or question box. Okay. If no one has any questions, you can certainly still type them in the chat if you like. But I would like to introduce you to Adam Colrus, who is the Assistant Vice President of Quality, Safety, and Health Policy with the Illinois Hospital Association. He is a certified professional in healthcare quality and a certified professional in patient safety. And Adam, I will turn it over to you.
Hey, Tracy, thanks so much. And I really appreciate you guys sharing everything that you've been able to do in Minnesota. And I know as your new partners in all this work, we're looking forward to leveraging that in our other states too. So thank you for all that work you guys have done and for sharing that today. As Tracy said, my name is Adam Colrus. I'm Assistant Vice President here at the Illinois Health and Hospital Association. Had the privilege of leading a lot of the hospital engagement network and hospital improvement innovation network work that IHA has put out since 2012. and have been excited to be able to co-lead a lot of that and a lot of the opioid work. So what I'd like to do with you guys this afternoon is just share with you about 4 things that we did, not just here in Illinois, but with our partners in Michigan and Wisconsin across the Great Lakes, Partners for Patients HIIN. So on the next slide here, we'll see kind of what the focus of my remarks is going to be. And that's going to be, again, 4 bucket areas. The first 2 I'll go into a lot more depth on. The Midwest ALTO project and then the Project ECHO Opioid Hub, 2 very successful programs that we ran through the Great Lakes Partners for Patients HIIN. So both of those programs touched folks in Illinois, Michigan, and Wisconsin. And then I want to touch more briefly on some of the ED prescribing guidelines that we put forth in Illinois, as well as, we'd be remiss if we didn't at least throw some food for thought out there about how opioid use disorder treatment, the different challenges that is facing during these COVID times, as COVID is impacting every aspect of our lives. So I'll go ahead and start by jumping into the Midwest ALTO project, which we're going to see on the next slide here. So the main take-home message for this project was that opioids are going to be our last resort and not our first option when we're treating folks who are walking into the emergency department. So we've been lucky enough through the Midwest ALTO project to have 2 separate cohorts of this run. We had one in 2018 and one in 2019. And so what I'm going to do for you guys here is just kind of outline what the Midwest ALTO project was. And then I want to highlight a lot of the canned resources that we have, which any emergency department, hospital, or system could pick up today and kind of shepherd you through that process of how we started reducing the prescriptions from an opioid perspective and enhancing the alternative treatments to opioids. And so on the next slide here, we'll see the high-level principles of our approach. So we focus on taking a multimodal non-opioid approach for a handful of conditions, which I'll highlight in just a minute. And our goal was to utilize these non-opioid approaches as our first-line therapies. So opioids is always going to be second, but they can be given as rescue medications. A really important point here that we stressed to all the emergency departments was just because you're engaging in the Midwest ALTO project does not mean that your emergency department is going to be opioid free. We know opioids have a time and a place, and so this is not cutting off the valve, if you will, for that clinical resource that clinicians can go to if they need it, but it's instead saying how can we approach certain conditions and say every time across the board that clinicians throughout our ED are going to look at non-opioid approaches first. And then the last couple points here are really around patient-family engagement. So we had some good resources on how to have realistic pain management discussions and setting goals that aren't opioid related with your patients. And then also discussing the potential pitfalls and downfalls of opioids. So those addictive potentials and all the side effects that come with opioid treatment. So that patient-family engagement lens was definitely a part of this. On the next slide here, we'll start taking a look at a little bit deeper dive on some of those principles that I've already touched on. So again, non-opioid medications are kind of the first foundational principle here, using opioids as rescue therapy and using them sparingly. And then, like I said, we targeted these 6 conditions that you'll find in the middle of the screen here: renal colic, opioid-naive musculoskeletal pain, opioid-tolerant low back pain, fractures or joint dislocations, headache and migraine, and then chronic abdominal pain or gastroparesis. So we weren't saying across the board that we're going to have an opioid-free solution for every condition that walks in the door, but the aim of this project was to say, let's take these 6 conditions that we know we have evidence behind and effective treatments that could be put in place to relieve the patient's pain, to keep patient satisfaction high, but to not use opioids. So this is kind of the starting block. And our hope was that after some of our emergency departments adopted these 6 clinical pathways that took time to put into play, that maybe we could branch out into some other conditions as time went on. And then again, the 5th principle here, again, touching on that patient engagement discussion as it pertains to pain management and addictive potentials. So the next slide here, I'll get into a little bit of the nuts and bolts of how the project looked, what our objectives, goals, and aims were. And, you know, a ton of credit here goes to our colleagues in Colorado at the Colorado Hospital Association, who really lit the torch and carried the torch on the ALTO front here. I was fortunate enough to go with some of our colleagues in Michigan to spend a couple days in Colorado, and we went to some ALTO emergency departments. We saw the trainings take place, and we really took the playbook from Colorado of how to create a program around ALTO and spread that. And so a ton of credit goes to them. In the first paragraph here, you can see the impressive results that they had in Colorado, you know, dropping their prescriptions by about 36% across 10 hospitals. And that's old data. As of today, there's almost 100 emergency departments. Almost the entire state of Colorado functions under these ALTO principles for these 6 conditions. So a lot of credit to them. In Illinois, Michigan, and Wisconsin, we said, okay, we're kind of the first group that's doing the second test of change on this, and we're doing it with 3 different hospital associations across 3 borders. So we tempered our approach and our goal a little bit, set the reduction of administration of opioids by 15%, and we'll take a look at our numbers here in just a little bit. So the next slide here is going to show the design of the project on a high level. So we ran this across our 3 states. We thought it was critical that we had subject matter expertise kind of embedded at the state level, but then that we're able to communicate across our 3 states. So we identified a physician, a nurse, and a pharmacist champion, one of which was embedded here in Illinois. The physician lead was in Wisconsin, and then our nursing champion was in Michigan. And we had weekly calls where the ALTO participating emergency departments would call in, and they had a chance to liaise with and connect either successes or barriers with our nurse, physician, and pharmacist champions, as well as their peers. And so it was kind of an all teach, all learn strategy. Before we jumped into those weekly calls, though, we had a pretty intense full day kickoff session in which we went through the entire ALTO philosophy, presented the clinical pathways, and we presented a pathway to implementation from a quality improvement perspective. And so what I'm excited about is the fact that that training piece, all those materials, all the great work we did within Project ALTO are compartmentalized. We have a lot of recordings that you guys could even tap as well. So the knowledge is there to be able to replicate this on your own, either as a standalone hospital or as a part of a system, and we'd be happy to share some of the successes and how you could do that post this webinar if you have interest. But all this to say, even though there's not a current ALTO cohort going on, I think we did a good job of capturing all that information so you guys could replicate this at your own organizations. So the next slide is more of a pictorial view of how the phases and the timeline of this project looked, right? So, and a lot of these hyperlinks you can download, and we'll make sure you guys get these materials post the webinar. But our first phase was communication with executives and that buy-in. And so we've got a nice commitment form which outlines, you know, the steps that emergency department would have to commit to or take if they wanted to engage in this project fully. And so we took a couple months there to recruit hospitals and get the buy-in that we needed. And then the second phase, or step 2, was really the meat and the bones, the 4 months of training, communication within the hospital of what Project ALTO was, and then how clinicians were supposed to clinically react to those 6 conditions when they walked in the door. So that was the bulk of the work there during those 4 months, was really communicating this to physicians and nurses, in quality leads, emergency department leads across the organization. And then after that education took place, and we'll take a little deeper dive into that education in a minute, after that education took place, we then started collecting data. And so we've got a pretty robust data set, which is nice, but really just a couple outcome measures, which we'll take a peek at. But we've been impressed to see the numbers that we have seen across the emergency departments in the 3 states who have engaged in this project. So on the next slide, we'll take a look at the population, which is very broad here. We basically were looking at any adult over the age of 18 who walked into the ED. From a data perspective, we collected, I know this says 3 to 6 months, but with almost all of our hospitals, we were able to secure a year of baseline data from the emergency departments. So we got a really nice look at what prescribing patterns look like pre-ALTO. And then post, we collected 9 months of implementation data, which showed us from an opioid prescription perspective, if those prescriptions were going up or going down or staying the same after we instituted these ALTO principles for those 6 conditions. So the next slide is going to look at the measures themselves. Again, 2 main outcome measures with those data sets that I just mentioned. So we got the nice year or so of baseline, and then about 9 months of implementation data. And these were the 2 things we were tracking. A, the number of opioids that were administered per 1,000 ED visits, and then B, more on the process side, but importantly, were the alternatives to opioid strategies that we trained folks on for those 4 months. Were those taking place more than they took place before? So were we seeing prescriptions drop, and were we seeing alternatives to opioid strategies being used? Hoping that the first one would go down and the second one would go up. And so the next couple slides here are going to take a look at how our data panned out. So for that first outcome metric on did our opioid prescriptions go down as a cohort, the answer was yes across the 3 states. So you can see the blue line here is our baseline, and then the orange line is our performance. And across Michigan, Illinois, and Wisconsin, we were able to reduce opioid prescriptions by a little over 10% over the time period of the first cohort. And the next slide is going to show you our ALTO rates. So this is kind of the inverse. Here we were hoping that the rate would go up. And you can see our baseline there in blue, and then the performance rate in orange. And as a tri-state conglomerate, we did enhance the alternatives to opioids that clinicians were practicing by a little over 13%. So in the next slide, we will take a look at the resources that we have baked in, which you guys can all take advantage of now to try and recreate some of the gains and the outcomes that we achieved. So there's 4 things that we'll take a quick peek at here. The first is the pre-launch checklist. The second thing are the clinical pathways. And then we'll take a look at an action planning document. This action planning document we actually created in between our first and second cohort because we saw a need there. And then a communications toolkit, which was new to our second cohort as well. So in the next slide, we can take a quick peek at our pre-launch checklist. So, you know, if you're sitting there and thinking about how this could be operationalized, you're probably right if you're thinking, man, this would take a village, and it definitely did. There's basically not a stone unturned from a personnel perspective in the ED that we wanted to have be a part of ALTO if we were going to do this the right way. So there's several roles, from an ED nurse director to a physician director to pharmacy to quality to frontline staff across the board that we wanted to engage in rolling this out the right way. We thought that it was really critical that the more prescriptive we could be in saying, hey, these are the important steps that these individuals would need to take over the course of the 4 months if you guys really want to get this thing going, the better. And again, a lot of this was adopted from some of the great work in Colorado, where they saw that, you know, a 36% reduction, and really categorized what the key action steps were that got hospitals to that level. So we adopted some of these, we localized them, and put some of our insights into them. But this is a really nice blueprint for what folks would have to do if you're going to launch ALTO. The next slide is going to take a peek at our clinical pathways. So this is the meat and the bones here. This is the clinical blueprint of what do clinicians do, how do they react when renal colic walks in the door, when chronic abdominal pain walks in the door, with that foundational knowledge that opioids are not going to be first. So we have here kind of our first line therapies outlined for each of these, and I know these are screenshots. It's definitely a more robust document, and would be happy to get this out to you folks. But again, this is one that we adopted largely off Colorado, but we did tweak some of these with our physician and nurse lead and pharmacy leads input. So this is kind of the blueprint, though, of over those 4 months, the education that would take place and trying to embed the clinical pathway knowledge to your clinical teams. And we've got a whole treasure trove of PowerPoints and slide decks for physicians and for nurses as they pertain to these 6 different conditions. And we've got some nice recorded webinars presenting those as well. So even though we don't have that live cohort going, I think that the body of knowledge out there has been captured to be able to replicate this without a full cohort. So in the next slide, we'll look at the third resource that you guys could tap, which is the action planning document. Again, this is one that we developed after seeing how it went with the first cohort, and we thought maybe that the checklist, the pre-launch checklist, which was that first document we looked over, would be enough. But we realized that it'd be really nice for, especially for the QI leads, if they could have that nice 30, 60, 90-day action plan that they were operationalizing, before education even started with their clinicians. And so this action planning document was a nice compass for the project leads or the QI directors to have as they shepherded their emergency departments through this process. So this is, again, a nice action-oriented document. And then the last document on the next slide is going to be the communications toolkit. And so the communications toolkit was really nice as well, because we just begged, borrowed, and stealed a lot of information that hospitals put together who were launching an ALTO project, so that other hospitals who wanted to do this wouldn't have to reinvent the wheel. So on the first screenshot here on the left, you can see about 7 different elements that are included in this communications toolkit, everything down to the nitty-gritty of like the staff emails that were sent out to your staff communicating what ALTO was. And there's a screenshot of that to the right, but also some really good media talking points, stuff that you can put up on your website, press releases, of course, all of our PowerPoints and newsletter articles. So basically, one of the things that Colorado realized and that we realized as well was that if this is going to be done effectively, it does have to be that village mentality, and no shortage of communication could take place. The more that we communicated it, advocated it from leadership on down, that this is going to be the way we were rolling clinically with these 6 conditions, the better. And so there's a lot of good kind of institutional knowledge here from the ALTO hospitals that have went before you, if you will. So that's a really good resource. So next slide, we will start getting into the second big programmatic bucket that I want to touch on, which is the Project Echo Hub that we launched here in Illinois. And this is in partnership with Southern Illinois University Healthcare. And really the impetus behind this particular project is the data graphic that you'll see on the right. So this data graphic on the right is obviously the state of Illinois, and there's 50 plus counties in the state of Illinois. This is an old document, and we have changed those numbers since. There's 50 plus counties on this graphic that are completely blank. Those counties represent counties in which there is not one clinician who is X-waivered, or who could prescribe buprenorphine, methadone, or treat a patient who has opioid use disorder. And so, I know we read and hear a lot about MAT deserts, but you can clearly see, especially in kind of our southeastern region of Illinois, region 5 there, how big some of these deserts and gaps are. And if you had somebody down there in one of these counties that was opioid use dependent and wanted to get treatment, how far they'd have to travel to find a clinician who could even start treating them. So this graphic alone was kind of the the burning platform that we had in Illinois. And we said, given this reality, we want to do two things. And so the next slide is going to highlight our first objective. And the first objective was to increase the number of providers that have their X waiver. And I know Minnesota's done a lot in this. And they talked about some of their boot camps, which sound amazing. We did something similar in which, we wanted to simply find physicians or any clinicians in any of those states that were desert states and get them trained up to get their X waiver and their Data 2000 waiver. So we did that pretty effectively. We had about almost 150 folks that we were able to get X waivered, but we knew going into this that it wasn't just getting a waiver connected to a clinician. And so that's where we have our second objective on the next slide, and this is where the Project ECHO Hub comes in. If you look at some of SAMHSA's data, I know that they say, and this is a little bit old, but close to 40+% of clinicians at one point in time a couple of years ago who actually were X waivered were not exercising that license. They were not prescribing because of all the hurdles that come with prescribing buprenorphine and some of these other treatments. And so we knew that it wasn't enough to just get clinicians trained and certified to prescribe, but we needed to work with them on addressing the barriers to prescribing. And so we say that our Project ECHO Hub was all about activating newly minted X waiver providers to be able to get out there and start treating OUD patients. And so the next slide is a look at the Project ECHO curriculum that we put together. For those of you that aren't familiar with Project ECHO, I think everyone on Earth now knows what Zoom is. I used to have to explain what Zoom was a few years ago when we started this, but I think that's in our nomenclature now, thanks to COVID. But Project ECHO utilizes Zoom, and it's a pretty simple concept. You get a multidisciplinary hub of specialists together, and that was our team at Southern Illinois University. It was an awesome team. It was a mix of psychiatry, clinicians, nurses, folks who have been X waivered, and that team puts together very short didactic presentations. And so our ECHO Hub was 12 courses. Each of those courses was only an hour, met once a week. And basically the first 15 or 20 minutes is didactic, and it's from that hub team at SIU, the clinical specialist. And they give about a 10 to 15 minute presentation via PowerPoint on a topic. And so here you can see on this screen, this is kind of the first 7 topics that we covered in our ECHO Hub. And then the rest of that ECHO session, though, the next 40 minutes is case-based learning. And so that's when the newly minted X waiver providers across the state would bring their cases to the table, their struggles, their issues, and the SIU team would address those, and then their peers would address them as well. So it's kind of that all teach, all learn environment. And the next slide touches on kind of the final 5 sessions of our ECHO Hub, the 12 that we had. And so high-level descriptions here of those sessions. Again, have all these PowerPoints. Happy to share any of these with you guys. Some of these, I think the majority of these hubs are also recorded, so I think we could even get those to you guys. But there's not currently a hub that we have rolling with ECHO and opioids, and we hope that's going to change soon. But we were able to capture a lot of good knowledge here. The next slide is also going to show you beyond just the PowerPoints or those sessions, some other few other things that we did within ECHO that may be of benefit to hospitals now. The next slide is going to highlight the first one, which is pre-test and post-test. And so before each ECHO session, we'd have the clinician take a pre-test. And then at the end of the ECHO session, we'd have them take a post-test. So we're kind of gauging the level of competency that clinicians were enhancing or not. And we did find, we haven't got the analysis back yet for opioids, but we've done another ECHO Hub with hypertension, and we found a huge jump in competency of clinicians pre and post. I'm sure we're going to see that with our opioid stuff too. But again, these pre and post tests, are available for us to share with you guys, and they kind of accompany and dovetail the didactic PowerPoints that you saw on the slides prior. The next slide is a representation of kind of the case presentation forms. And again, for ECHO, how this works, it's all HIPAA compliant. We don't have any PHI, but there is kind of a process that hospitals would have to go through to share their story first. So we can assure that that happens. And so we would use these case presentation forms. And then the next slide kind of shows you what would be produced out of these, again, which would be shared in the ECHO Hub. So we take that form and then we populate it on a slide. So kind of telling the story of what the clinician was struggling with, what question they wanted to pose to the group of experts, and then we would tackle those issues. And so I think these screenshots are actually from our hypertension hub. But again, we've got kind of a whole array of slides like this for opioid use disorder ECHO Hub that we could share, that other clinicians brought to the table that were then discussed. So this is kind of that case-based learning aspect of it. So the next slide is going to be our last one for the ECHO slides, and really this one just hits home how this is kind of was an all teach, all learn environment. We're really hoping that we can find a way to integrate this work again, but it was just a great way to connect clinicians from across the state with specialists on a specific topic area. Like the motto of ECHO is, to spread knowledge and not people. And especially this day and age, as we're going to be adopting more and more virtual mechanisms of programming, I think that Zoom and ECHO are going to be great opportunities for us to continue some of this opioid work and training and exchanging of knowledge. So our next slide, and I only have a few slides left before we get to some questions. I don't want to spend a ton of time on these last two because this one, almost all of our states have probably worked with our local College of Emergency Physicians to put forth their own guidelines for opioid prescribing. I know that our states in Michigan and Wisconsin had done so as we're getting into the ALTO project. And so just a hyperlink here of the prescribing guidelines that were put forth by the Illinois Health and Hospital Association and ISEP, our College of Emergency Physicians, for your guys' reference if needed. And then in a lot of the opioid, the ALTO resources will get you. I think we also have Michigan and Wisconsin's prescribing guidelines baked in there as well for reference. And then lastly, this one is just more of a transition slide, the next slide, into the current environment we're all in with COVID. And so a couple pieces of literature that have been floating around our GLPP organizations. One, asked some questions about opioid use disorder and how that's being affected during the COVID crisis, knowing that buprenorphine visits are being done by telemedicine, but all the other limits that come with that, knowing that there was, a waiver put forth for methadone that's allowing for a few weeks supply for outpatient, but then ramifications of that, and basically just asking these questions, given how clinicians are being, and patients, clinicians and patients are having to continue or try to continue treatment of OUD under these new circumstances. Is that going to lead to more diversion? Is there going to be more abuse? How are our outcomes going to look on more of a macro scale? And we thought this AMA website did a pretty good job of at least shepherding us through some of those questions and making us think about them. And then the last slide I have here, it touches on pain management. And so during this opioid epidemic in the middle of a global COVID pandemic, what are some of those guiding principles of how clinicians are transitioning to remote care, utilizing technology, and kind of discussing those lessons, what future pain management might look like? And so there's 4 kind of foundational components here that this article, which is linked at the bottom, walks through, which we thought was kind of helpful and illuminating. And so all this to say, we wanted to highlight this OUD in the middle of the COVID piece and these questions, just to share with you guys as well that, we're doing our best to try and secure more grants, resources, and funding to continue our opioid work. beyond what our partners in the Minnesota HIIN have done and what we've done in the Great Lakes Partners for Patients HIIN. I think we're thrilled that we're kind of combining forces now. And so the hope is that we're going to have more resources to continue some of the great work we've talked about here and of course, expand upon it, but that all of that work and programming is going to have to be seen now through that lens of COVID. And so when that time comes, we will welcome your input, expertise, and guidance on how you think we could put forth effective opioid programming during the lens of a pandemic or, after the dust settles and once we see how life is going to function post. So with that, I want to thank you guys for taking the time to listen to me talk so long about opioids, and Tracy as well. This is a great opportunity for us, and hope it was illuminating for you guys. And I want to pass it along to our colleague Annie Allen at the Wisconsin Hospital Association. I think she's going to tee up some Q&A and has some kind of closing comments for us. So Annie, without further ado, I'll go ahead and pass the ball over to you.
Thank you, Adam, and thank you, Tracy. I think there was a lot of great innovative work that you guys have shown a good portion of it across the 4 states that occurred throughout the HIIN. And just because the HIIN ended doesn't mean that this work stopped. A lot of these great toolkits can be taken back to your hospitals and locally implemented. All 4 hospital associations are available, and reach out to us. We're more than happy to help you. Melanie, I do not see any questions in the chat. Do you?
There are no questions in the chat or questions box.
All right, we'll give you guys a few seconds here to see if you have any questions. Feel free to type them in. As you can see, our next 4 webinars in the series are teed up on this final slide. We do thank you for taking time out of your day today to join us. And we hope to see you again on June 18th when we cover sepsis. And I still don't see any more questions in the chat. So with that, thank you all for attending today. Reach out with any questions or things that you need. Otherwise, we'll see you in June.